So before we get started, I want to really encourage you guys, as you listen to this review, to try thinking about everything I talk about um, with the nursing process in mind. Be thinking about whenever you study these medications, what's the nursing role in that? What patient education should you be providing? How is it working in the body? And based on that, what assessments is that going to provoke in you? What could go wrong with these medications? What do you need to report to the physician? So much of medications we want to just memorize, but I think you discovered, a lot of you with exam too, that memorizing facts just isn't enough. You've got to memorize those facts and then be able to synthesize it into the nursing process and make those clinical judgment calls that you'll have to make when you're really working. And so I challenge you to do that when you're studying for this test this time and see if you don't do a little bit better. Okay. Let me get to the first slide. We're going to start with the anticholinergics. What is an anticholinergic? What does that work with? What does cholinergic mean even? Let's start there. So an anticholinergic works with the parasympathetic nervous system. And if you remember right, if we go back to our anatomy and physiology, and remember that the parasympathetic nervous system controls really what's happening in our body in a restful state, when we're not stressed, when things are going really well. The sympathetic nervous system controls what happens when we need to take immediate action, right? That's our fight or flight response. That's how it's commonly referred to anyway. I'd rather liken it to a fight or unfight response, because really the parasympathetic system, we're not running away from anything. We're really just in a restful state. And so think about the parasympathetic nervous system and what that controls when we're looking at what we're going to block. Okay, because anticholinergics, let's look at that word. First of all, anti means not, and then cholinergics, let's break that down. So I see the word colon there, and I know I see the word choline here. And so if that helps you remember that this is the acetylcholine is the one that's connected to the anticholinergics, we're going to try to block that at the receptor site, because we want to block the anticholine at the cholinergic receptors throughout the body. Okay, so acetylcholine has to bind to its receptor to signal a parasympathetic response, right? Anticholinergics will compete and bind to those receptors, which prevents the parasympathetic response from happening. So if we look at the graphic and see what the parasympathetic nervous system controls, we can see what the opposite effect would be if we prevented it, right? So during a sympathetic response, what we want to happen during that stressful, I need to take action moment, is we need oxygen to be shunted to all the vital organs that play there. So we're talking about the cardiac system, the respiratory system, the brain, and when we say digestive system, I'm not talking about this is the time to be like digesting a big cheeseburger, but it will help glucose get to the cells. And so in that sense, it does stimulate that glucose to be used for energy. Okay. Otherwise, it slows all the rest of it down. Anything else? So the major sites of action of the anticholinergics would be the heart, the respiratory tract, the gastrointestinal tract. If we look at the other side, the urinary tract, bladder, intestines, all that stuff gets slowed down. The salivary glands, the eyes on the sympathetic side will dilate because we want that extra light to be in there. We want to see really well. to be able to handle whatever that fight a bear response is that we're looking at. Everything else that's not vital in that moment kind of slows down. So when we're looking at that, we're talking about the sweat glands and the oral secretions, even the secretions into the intestines and that mucosa and stuff really slows down, which means that we're slowing down peristalsis. We're slowing down the urinary system, which means I could experience urinary retention as the bladder relaxes and isn't contracting the way it should. So everything happens opposite. You need to understand that when we say anti, that means what would be happening in the parasympathetic now has been very much slowed down, and we've shifted over into a sympathetic response. And so thinking about that, what would happen if we block it, and what will be your nursing assessments and priorities? What education should you be providing to the patient? What indications should you be watching for? Okay, so if we're looking at cardiovascular, we're going to be increasing the heart rate, right? Respiratory, we're going to experience bronchial dilation, yet we're going to have the mucous membranes dry up. The GI tract will experience a decrease in motility and a decrease in the secretions and salivation. The urinary system will have a decrease in bladder contraction and an increased constriction of the internal sphincter, which can result in urinary retention. And it's important that you realize that if you've got patients on, say, atropine, you're going to be really watching their intake and output there, the I's and O's. You need to know what's happening there. When we're talking about skin, we're going to experience reduced sweating, which can affect the temperature regulatory system. The eyes, the pupils dilate, and it can also increase intraocular pressure. That occurs because the ciliary muscles and the sphincter muscle of the iris are innervated by the cholinergic nerve fibers. Anticholinergic drugs can also affect the central nervous system in different ways. It's very dosage dependent. So small doses, we will see a decrease in muscle rigidity and tremors, and we can actually see an increase in the heart rate with small doses of anticholinergics. Large doses cause the opposite. We can see drowsiness, disorientation, hallucinations, and those higher doses also block the inhibitory vagal effects of the pacemaker cells, which is why it increases the heart rate. And we give that for symptomatic bradycardia. I think atropine, in my experience anyway, I work ICU, and so usually when I'm giving atropine, it's for symptomatic bradycardia where we need to get that heart rate back up. But it can also be used for other things like second degree heart block and totally different things for like a surgical patient might be given atropine to decrease oral secretions so that we decrease the risk of aspiration pneumonia, especially if they're going to have an oral airway in place. Or we use it to dilate the pupils for different reasons. You might have it just for your routine eye exam. We'll use it in surgical centers before like cataract surgeries or my mind just went blank, which is funny because I worked in an eye surgical center for a year. But anyway, any eye surgery, they want to dilate that pupil. So that being said, because it does affect the intraocular pressure of the eye, it's contraindicated in patients that have glaucoma. Okay. In the respiratory tract, because they decrease secretions from the nose, mouth, pharynx, and bronchi and promote bronchodilation, they're often used to treat COPD and asthma, though they're never used for an acute episode of asthma. because we don't want that to replace a rescue inhaler. They might be used in the treatment of IBS because they slow down peristalsis, and they are very useful in the treatment of overactive bladder spasms and incontinence. The drug that you'll see a lot for that is oxybutynin. If you work med-surg at all in any way, you're going to give tons and tons of oxybutynin, maybe even if you go long-term care, I would imagine. And I already mentioned they might be used preoperatively to control oral secretions. Again, they are contraindicated in people with glaucoma. You want to make a note of that somewhere. That might show up on a test. It can increase the effects of digoxin. So now, knowing the way that anticholinergics work and the related physiology should assist you in the safe assessment and nursing care of patient taking these drugs. So if you're a nurse and you're giving a patient atropine, and we know that we are inhibiting the parasympathetic response, what nursing cares might you want to include for that patient? So I'm thinking, well, maybe I want to make sure we're doing frequent oral cares. If that patient's got dry mucus secretions dried up, they are at risk for developing mouth ulcers or dental caries. You could increase their fluids, encourage them to chew sugar-free gum or suck on some hard candy. You for sure are going to want to be assessing their bowel sounds more frequently and monitoring that urinary output, like I said before. And then also be aware that they're at higher risk of developing a blockage of the bowels because we don't have that normal peristalsis working like they should, and we don't have the water secretions coming in to help flush the colon. Let's see, if we're looking at the skin and we're slowing down the sweat glands, that very much controls or contributes to thermal regulation. And so you want to caution these patients to maybe not do as extreme exercising or staying out of saunas, hot showers, hot tubs, because it actually could lead to a case of hyperthermia because the body just can't regulate the temperature like it normally would. Let's see what else. You might want to encourage them to increase fiber and fluids and exercise, like be walking, to help those bowels move a little bit better to prevent constipation. Maybe add psyllium products or a stool softener even. And then if you've got patients that are going to be outside in the sun and their eyes are dilating, caution them to be wearing sunglasses to prevent those eyes there. So the drug of the prototype for anticholinergic is atropine. And also cogentin, benztropine, I think was on your list. But they kind of all systemically can do the same thing. If you're using atropine drops, that's not systemic. That's very much localized. Another thing that we might use these anticholinergics for is in cold medications for the common cold because it dries up those secretions in the nose. That helps a lot. Okay, or I can't talk. A scopolamine patch is used frequently for motion sickness, but I love it when you can get a doctor that will prescribe it for a patient that's going to go in for surgery because it's very, very, very beneficial to prevent that nausea that can happen as they're coming out of anesthesia. Okay, so the next up on our list is going to be the alpha adrenergic blockers. You can see on this graphic here that it works by getting in the way of the receptor where norepinephrine would bond. Or it could, if you look over here on the right side, this is a covalent bond where it sits there, but norepinephrine can still bind because the The alpha blocker is down a little bit lower, but it makes it less effective. Over here, it's totally blocked, and you can see norepinephrine just cannot use that site. But either way, they both cause venous and arterial dilation, and they reduce the peripheral vascular resistance, which means that they lower blood pressure. Okay, I think your prototype drug here is prazosin, or Minipress is the other name. It can also lead to pupil constriction, and it can reduce smooth muscle tone in organs such as the bladder and prostate. And so another medication that's in this classification that's used a lot for bladder and prostate is tamsulosin. Flomax is the brand name for that. You'll see that a lot in your careers if you work bedside at all. So as a result of the blood vessels dilating, the patient experiences increased blood flow to the skin and other organs. That decreased peripheral vascular resistance helps decrease blood pressure, and that's why it works so well for this. But because that alpha adrenergic blocker causes smooth muscle to relax and the blood vessels to dilate, it also increases local blood flow to the skin and other organs while it reduces the blood pressure. So it's taking that fluid that's in the vascular system, and it's kind of putting it into some other areas of the body, which can be a good thing for some disorders. This is a really, really good drug to use for Raynaud's. So if you remember, Raynaud's causes that constriction down in the lower extremities, like in the fingers and stuff, where blood flow just can't get there, and they might have some numbness or tingling, and certainly their fingers are always really cold when you assess them. They're just purple and cold. And so to give an alpha adrenergic blocker as it pushes it down into those extremities, it's very, very beneficial. It also can be used for pheochromocytoma, which is a catecholamine-secreting tumor that causes severe hypertension. So let's see. Alpha adrenergic blockers affect the sympathetic tone, or the state of the partial constriction of the blood vessels in the body. The therapeutic effect of this depends on the tone that exists before administration of the drug. So this is really important for you to know. Okay, pay attention to this. So for instance, if the drug is given when the patient is lying down, only a small change in blood pressure occurs. In that position, the sympathetic nerves release very little norepinephrine. But on the other hand, when a patient stands up, norepinephrine is released to constrict the veins and shoot blood back up to the heart. So I'm talking about a normal person that's not taking an alpha adrenergic blocker. If you're laying down, the body just doesn't need as much norepinephrine to get the blood where it needs to go, because it's not trying to fight gravity, if that makes sense. And so when you stand up, it releases more because now blood needs to shoot up from the lower extremities to circulate to the heart, right? So what happens when I block that? I've used an alpha adrenergic blocker. That norepinephrine cannot get to that connector site, to the receptor site. And so I don't have that blood shooting back up to the heart like it should. I've got it pulling down into the feet. We have a name for that. It's called orthostatic hypotension. Orthostatic hypotension. If you're a nurse, you're probably very well aware of what that assessment looks like. If you're working as a CNA, especially in a hospital, I'm sure you're very well aware of what that assessment looks like. But the biggest risk of a patient that has orthostatic hypotension is a risk for falls when they stand up, right? It takes a second or 30 seconds or so for that blood to get from the lower extremities up to the heart and to the brain where it needs to be to get that oxygen there. And so this is a really, really important consideration as a nurse. If you have a patient that is taking this drug, that you instruct them to sit at the edge of the bed, let their feet dangle for 30 seconds. Plant their feet firmly on the ground and stand for another 30 seconds before they start to walk, because they're at extreme risk for a fall. Okay. Okay, so just to reiterate, if the patient receives an alpha adrenergic blocker, the veins can't constrict and the blood pools in the legs. Because blood returns to the heart is reduced, blood pressure drops. This drop in blood pressure that occurs when a person stands up is called orthostatic hypotension. I obviously do a lot better when I'm not reading and I'm just talking off the top of my head. Okay, so some considerations with this medication. Many drugs interact with alpha adrenergic blockers that can produce a synergistic or exaggerated effect that may lead to such conditions as severe hypotension or vascular collapse. Prazosin, or Minipress, is your prototype drug for the alpha adrenergic blocker. And it's often given with diuretics, with beta blockers, and many over-the-counter supplements such as saw palmetto that can cause syncope and even loss of consciousness. So you're going to want to be really clear in your nursing assessment and in your patient education that you are letting this patient population know that they should be not taking over-the-counter medications without clearing it with their doctor first. Even given with dopamine can increase the effects of the pressor, which could lead to an exaggerated rise in blood pressure. Nitroglycerin can produce hypotension due to excessive dilation of the blood vessels. So if you remember, I've already explained that this alpha adrenergic blocker does dilate the blood or the vessels some. And so if it's given with nitroglycerin that's dilating the vessels, that could produce a pretty good case of hypotension that's pretty excessive. So adrenergic drugs, again, including many over-counter drugs, can increase the stimulating effects of the heart. Hypotension with rebound hypertension can occur. Erectile dysfunction, including impotence and the inability to ejaculate, or priapism, I didn't say that right, let me get rid of this blocker there. Priapism, which is a prolonged erection of the penis, usually without sexual arousal, may occur, though it is rare. And that's just because it's shunting it down where it shouldn't be. So if we think about how alpha adrenergic blockers work in the body, what adverse reactions should we be watching for? Again, I already talked about the orthostatic hypotension, but it can also lead to severe hypertension when it's taken with those drugs that can potentiate. We could have experienced bradycardia or tachycardia, edema, difficulty breathing, lightheadedness, flushing, arrhythmias, angina or heart attack, spasm of the blood vessels in the brain, or a shock-like state. So if I'm looking at flushing, it's because, remember how I said that it sends it to parts of the body, like for Raynaud's or something, it's really good for that. But when it's sending that blood into the tissues, you would see that flushing there. If you're hypotensive, if you're if your heart rate's too low, then you could be experiencing that lightheadedness, that flushing. And certainly if you are that low, you're not getting the oxygen to the heart that you need, which you get the angina and you get that's the chest pain that could escalate to a full heart attack. So your nursing assessment should always include obtaining vital signs, especially blood pressure, when giving this medication. Assess for edema, because if the blood is not if it's shunting where it shouldn't be, or if it's pooling because it can't like the orthostatic hypotension where that blood is pooling, then you're going to see that edema there. Continually be watching for the patient for any of these adverse effects, and then also assess the patient's knowledge of their drug therapy. To help alleviate or prevent these complications, it's best to give these medications at bedtime because that will help minimize the dizziness or lightheadedness. Begin therapy with a small dose to avoid syncope. This drug is associated with something called a first dose phenomenon. And so that first dose should be smaller to let the body kind of get used to it, adapt to it before it's increased to a therapeutic level. Don't give sublingual tablets with food or drink. And always, always, always provide adequate patient education, which should include teaching the patient to rise from a lying or sitting position slowly, report dizziness or irregular heartbeat, don't eat, drink, or smoke while using the sublingual tablet, while it's dissolving anyway. Don't increase your dosage without first consulting your provider. And on a sidebar note, when talking about alpha adrenergic blockers, I should mention neosynephrine, phenylephrine, neosynephrine, which is a non-catecholamining adrenergic drug that's usually given topically as a nasal spray for congestion. I'm sure you have all seen phenylphyrine. I can't say it. I'm just going to call it the brand name, neosynephrine. I'm sure everybody has seen neosynephrine. That is an alpha adrenergic blocker that's topical. It works topically by stimulating the alpha adrenergic receptors in the smooth muscle of the blood vessels in the nose, and it results in vasoconstriction. The combination of reduced blood flow to the nasal mucous membranes and the decreased capillary permeability reduces swelling. That action improves respiration by helping to drain sinuses, clear nasal passages, and open the eustachian tubes. The most common adverse effect, write this down. You probably already, maybe you even experienced this, but the most common adverse reaction associated with prolonged use of more than 3 to 5 days is rebound nasal congestion. It can lead to a fairly quick dependence of the medication. So you stop taking it and you experience nasal congestion worse than you had before you started taking it, and your body becomes dependent on it. It's a true addiction to this medication, and it takes a long time of suffering through for your body to adapt back to the other way. I might mention too that eye drops do the same thing, though that's not part of your studies right now, but if you're using eye drops all the time for red eyes, that when you stopped, you could get that rebound effect as well. Other complaints of the neosynephrine are burning, stinging of the nasal mucosa, sneezing, dryness, and ulceration. Okay, let's go to next slide. I'm going to talk about the cardiovascular nervous system. There's a lot of medications here that control cardiovascular problems. The first one, let's see, components of the cardiovascular system includes the heart, arteries, veins, and lymphatics. These structures transport life-supporting oxygen and nutrients to cells. They remove metabolic waste products, and they carry hormones from one part of the body to another. So because this system performs such vital functions, any problem with the heart or blood vessels can seriously affect a person's health. Okay. Cardiac, I think when we talk cardiac, lipids follow, right? Because this is one of the biggest contributors to blockages of the heart, is to have all that fatty gunk in their closet causing for clogging it up. So Anyway, lipids are the problem. Lipids are the fatty part, and they're composed of cholesterol, triglycerides, and phospholipids, and are bound to lipoproteins and are transported in the body. They go through the vascular system. Cholesterol and triglycerides are the two primary forms found in the blood. Cholesterol is primarily used to make steroid hormones, cell membranes, and bile acids. So I think when we talk about cholesterols, we all just think it's bad, but the body really needs it to function and to repair cells or grow new cells. It's just when we get too much of it that we have a problem, or when the body isn't using it effectively. Triglycerides get a really bad rap too, but they function as an energy source, but are stored in adipose tissue. They're both water-soluble fats that must be bound to specialized lipid-carrying proteins that are called apolipoproteins. When these combinations occur, they're called lipoproteins, which I'm sure you've heard that term, lipoproteins. High-density lipoproteins are those are the HDLs. Those are our good cholesterols. They have a higher density of protein and fewer lipids. They remove cholesterol from the bloodstream and deliver cholesterol to the liver away from the tissues where it is broken down and excreted. The three other are composed of cholesterol and triglycerides and contribute to the plaque, to the atherosclerotic plaque in the blood vessels that can lead to occlusion in coronary events. So HDL good, the other three bad. They're necessary. I hate to call them bad. It's just when we have too much of it that it's bad. So here's some of the drugs that we use to control high cholesterol. We've got the bile sequestering cholestyramine. We've got the fibric acid. Lopid is the brand name there. Gemfibrozol is the generic. And then the HMG CoA reductase inhibitors. That's a really big name for statins. In the medical world, we just call them statins, okay? So these anti-lipid, I just want y'all to know it's 2 o'clock in the morning, and so that's why I don't have my words. So anti-lipemic drugs are used to lower abnormally high blood vessels or lipids, such as cholesterol, triglycerides, and the phospholipids. The risk of developing coronary artery disease increases when serum levels are elevated. These drugs should be used in combination with lifestyle changes, such as proper diet, weight loss, exercise, and the treatment of any underlying disorder. Bile sequestering drugs, such as cholestyramine, are not absorbed in the GI tract, but rather they remain in the intestine where they combine with bile acids for about 4 or 5 hours before being excreted in feces. This decrease in bile acids triggers the liver to synthesize more bile acids from their precursor cholesterol, which lowers the overall levels in the body. So that's how that works. That's how that's working. It's binding to the cholesterol that's already there, or to the bile acids, which makes the body want to produce more bile acids. And the liver has to use cholesterol to do that. And so by that rationale, it would lower your cholesterol levels by making it do the extra work to replace what you have taken away on purpose that the body does need to break down waste. So they do hang around for about 5 hours before being excreted, and so it's really important to know because they will bind to cholesterol or bile. They don't bind to cholesterol. They bind to bile acids, but they also bind to other things that are present, including medications. And so part of your patient teaching or part of your nursing practice is you need to be sure that you're giving that medication a full 2 hours before giving other medications, or 4 hours after giving medications, giving the body time to absorb the medications that you've taken. So constipation is a really common complaint, but it also might be accompanied by heartburn, nausea, belching, and bloating. Fibric acids, which is our gem fibrosol or your lopid, is produced by fungi, so that's a fun fact. And how these medications actually contribute to the lowering of cholesterol isn't really known, but it's thought that they might reduce cholesterol formation in its early stages, or that they might mobilize cholesterol from the tissues, increase excretion, and decrease the synthesis of triglycerides. But really, no matter how they work, we do know that they do work, and they do it by increasing the good cholesterol, the HDL, in the blood, and increase the serum's capacity to dissolve additional cholesterol. Adverse reactions to fibric acid includes headache, dizziness, blurred vision, arrhythmias, thrombocytopenia, and rash. GI effects may include epigastric pain, dyspepsia, nausea, vomiting, and diarrhea or constipation. It may lead to an increased risk for gallstones. Liver function tests must be monitored for increased enzyme levels. I bolded that, so that must be important. Liver function tests should be monitored for increased enzyme levels. Okay, so our last one are our statins. Let's see, statins is the rate-limiting enzyme in cholesterol synthesis. Well, that's not really true. HMG-CoA reductase is what I just said. 2 o'clock in the morning brain. HMG-CoA reductase is the rate-limiting enzyme in the cholesterol synthesis. So when we're looking at a statin, that's the HMG-CoA reductase inhibitor. An inhibitor is the important word in that definition there, because we want to inhibit that enzyme from being produced. And we do that, when we do that, statins lower the blood cholesterol by decreasing the rate of production by inhibiting the enzyme needed to produce it. When less cholesterol is produced, the liver increases the number of LDL receptors to recycle LDL from the circulation back to the liver. So remember, the LDL is not our good cholesterol. And if we're trying to make more HDL, the body is bringing the LDL back to the liver to convert it into HDL, which means we're pulling the bad cholesterol out of the bloodstream. And that is the whole premise for using these statins. We bring them back because we need those. We need those to produce steroids, bile acids, and cell membranes, right? They are contraindicated in pregnancy, liver disease, or elevated liver enzymes. So again, this is another medication where we're going to be wanting to watch those liver enzymes through lab work. A clinically important adverse effect is myopathy. Also, I have this in bold. That might show up on a test, maybe. What is myopathy? Well, that's muscle pain that might progress to a serious condition called rhabdomyolysis. Now, rhabdomyolysis is where the muscle breaks down when it shouldn't. It's the breakdown of muscle protein accompanied by myoglobinuria, which is where it's eliminated in the urinary system. So we can find it in a urinalysis. Rhabdo can lead to acute renal failure and even death. It appears to be dose-dependent and is more common in patients receiving a statin in combination with cyclosporine, gemfibrozol, or erythromycin. It can be reversed by discontinuing the statin if caught early enough. So nursing assessments are important here, guys. Really important. How would you assess for rhabdomyolysis? I mentioned before that it is that the patient could experience myopathy, which is that muscle pain. So part of your nursing assessment should be instructing the patient to immediately report any signs of toxicity, which includes muscle soreness and also a change in the urine color, because when that comes through and that protein comes through in the urine, it changes it to a dark, kind of a rusty color. Rhabdo can be confirmed with elevated CK labs and a urinalysis. Okay, diuretics. How do we use diuretics in cardiac problems? I think we see this primarily in heart failure. I think when we think of diuretics, we think of heart failure, but it also can be a first-line drug used in hypertension, specifically a thiazide. Diuretics are drugs that accelerate the urine formation via a variety of mechanisms. The result is the removal of sodium and water from the body. They are the first-line drug for treating mild hypertension. Hydrochlorothiazide is the drug of choice there. Thiazides are not used in patients who have renal insufficiency. Loop diuretics, such as furosemide, or Lasix is the brand name there, are usually recommended for these patients because they don't depress renal flow. Thiazide diuretics interfere with sodium transport across the tubules of the cortical dilating segment of the nephron and increases renal excretion of sodium, chloride, water, potassium, and calcium. They decrease the excretion of ammonia, causing increased serum ammonia levels. They are indicated in the treatment of edema and hypertension. They lower the volume of fluid in the vascular system, which results in a lower blood pressure. Now, we're talking mild hypertension when we're talking thiazides, okay? Just mild hypertension. It's not a really strong diuretic like Lasix is. When a patient is first put on hydrochlorothiazide, maybe for the first 2-3 weeks, they might notice that they're going to the bathroom a lot more, but the body regulates to that fairly quickly and it stops being as noticeable. Where if you take Lasix, you know it. Every time you take Lasix, it should have a pretty significant effect. Okay, so thiazides also relax the walls of the small blood vessels, which also reduces afterload. Reducing both preload and afterload makes them very effective for the treatment of both heart failure and hypertension. It's not as effective if renal function decreases because the delivery of the drug to the site of activity is impaired. Therefore, renal labs should be monitored. Interactions with the drug digoxin may result in an increase in a level leading to digoxin toxicity as a direct result of hypokalemia. So if you're giving these diuretics and the patient has a low potassium level, that could lead to a digoxin toxicity if they're taking digitalis as well. Potassium should be monitored routinely in addition to renal function. Also, frequently monitor weight and blood pressure. Loop diuretics inhibit sodium and chloride reabsorption in the ascending loop of Henle, increasing the excretion of sodium, chloride, and water. It can also increase the excretion of potassium to higher degrees than thiazides do. So you might, if you've got a patient with hydrochlorothiazide, you might have a patient, they might have to take a potassium supplement, but it's really not as likely. But if you have a patient taking Lasix, you should expect a potassium order to follow it, and if it doesn't, that's a good clarification to make with your provider in that hospital setting, okay? And you should expect a BMP to be run every morning with your morning labs to see what that potassium's doing. A lot of these patients that are taking Lasix in the hospital don't take it at home. And so you want to give extra monitoring there to make sure that they are tolerating it well. Potassium, I mentioned, should be monitored carefully, and potassium supplements are usually advised. We're not really talking about potassium in this unit so much as we did last, but I will mention that oral potassium is utilized by the body so much better than IV is. It should be your first choice if possible, because the body just absorbs it a lot better, and it's a lot safer to give than IV potassium. And remember, we don't ever push potassium straight into an IV, right? That is mixed with saline, and it is run very, very, very slowly through an infusion pump, no faster than 10 milliequivalents an hour, which 10 would be mixed in a bag of 100 NS, which means, you're running it over an hour, 100 mils an hour, to get 10 little milliequivalents in there in the body. It's pretty crazy. When you could give a 40 milliequivalent tablet in one dose PO and have no adverse effects at all. So that's always should be our first choice, but there's times when a patient can't take oral medications. And that potassium pill, if you've seen it, is like the size of a horse pill. So anyway, it's important that the patient be educated to the signs of hypokalemia, which include leg cramping and muscle aches, and also safety precautions associated with that orthostatic hypotension. For sure, with Lasix, we could experience patients are at extreme risk for falls during the time that they're actively diuresing. IV Lasix especially happens fairly quickly. Please make sure that your patient can get to the bathroom on time, that they're not hooked up to a bunch of monitors, and that they're scrambling and that they're tripping over things, and make sure they know how to use their call light, and if they need to ambulate with a walker, that you have everything ready. If they struggle with that, it's a really great idea to just have a commode right next to the bedside, so all they have to do is help stand, pivot turn and be sitting. But keep that in consideration as for your nursing cares. Loop diuretics may increase the risk of lithium toxicity. Let's see. It's important to educate the patient to the signs of hypokalemia, which include leg cramping and muscle aches. Okay, hypokalemia could manifest as leg cramping and muscle aches, and if they experience that, they need to let you know, because we know that hypokalemia can lead to cardiac events, and we know potassium is lost when we're giving Lasix. Okay, they reduce the hypoglycemic effects of oral anti-diabetic drugs, possibly resulting in hyperglycemia. Use with digoxin carries the same risks for toxicity as associated with thiazides. Patients taking loop diuretics run the risk of developing electrolyte imbalances that can trigger arrhythmias. Nursing assessment should include monitoring for signs of hypovolemia, checking blood pressure and heart rate, and twice daily weight checks. So like each shift, during your first assessment, weigh your patient. And should establish baseline values before therapy begins. Indicated for use in acute pulmonary edema, heart failure, edema, and hypertension. Patient teaching should include safety precautions such as fall risk due to lowered blood volume, reporting leg cramping, and rapid weight loss. Educate about eating foods rich in potassium and taking supplements as ordered. So on the flip side, our last diuretic is spironolactone, which is a potassium-sparing diuretic. It's a weaker diuretic and an antihypertensive effect than the other diuretics. But one of the advantages of using this one is it does conserve potassium. They are used to treat edema, diuretic-induced hypokalemia in patients with heart failure, cirrhosis, hypertension, and nephrotic syndrome, which is an abnormal condition of the kidneys. The nurse must monitor the blood pressure and heart rate, especially during rapid diuresis. Serum potassium levels must be monitored frequently in patients taking potassium supplements. Instruct the patient to avoid salt substitutes because they usually have potassium added to them, and potassium-rich foods, except with provider approval. So you don't want to drive them into a state of hyperkalemia, which could also lead to a cardiac event. Really encourage them to stay hydrated. Drinking water is best. Assess all patients taking any diuretics for potassium levels, evidence of excessive diuresis, hypotension, tachycardia, poor skin turgor, excessive thirst, or dry and cracked mucous membranes. Monitor and record the patient's intake and output carefully every 24 hours, or you might have a doctor that orders that to be strict eyes and O's, which means hourly. Usually in an acute setting, you will figure out your I's and O's at the end of your shift. If you're in an ICU, you're probably doing it hourly. So whatever your hospital protocol is for wherever you are, if you have a patient on a diuretic, you need to be aware of what's coming out as opposed to what's going in. And then a really great piece of advice is to give the diuretic in the morning or the early afternoon to avoid disrupting their sleep patterns at night. Okay, there is a really fun graphic about the nephrons, and I liked it because it shows you where sodium goes in, where sodium goes out. Here's that ascending loop of Henle, where the body should take in potassium, but it's blocked. Okay, and that's why this is where Lasix works, is here at the loop diuretics block here on the ascending. Here's the loop of Henle, and ascending means going up. So here's the loop where it's going up, and we see that sodium, potassium should get reabsorbed from the tubule, but that loop diuretic blocks it, and so we don't get that back in. Okay, we don't really see a deplete in sodium the way that we do potassium because it stays balanced with the water that doesn't come back in as well, because sodium and H2O kind of have a really their best buds, right? So you can see at other places here, over here is where the spirulactone, which is our potassium sparing pump, that we don't lose potassium there, and so when we're blocking something, we're not blocking the reabsorption of potassium. That should have already have happened through here. Anyway, you can pause and look at that as long as you want to. It's a good resource. Okay, calcium channel blockers. They inhibit calcium ion influx across the cardiac and smooth muscle cells. They decrease the workload of the heart. They're really, really effective in relieving angina, in lowering blood pressure, and in restoring normal sinus rhythm. So when we're talking about these, I'm talking about like diltiazem or verapamil. Diltiazem is a really, it's one of the chosen medications in converting or controlling AFib or flutter. They cause dilation of the coronary and peripheral arteries, which decreases the force of the heart's contractions and reduces the workload of the heart. They do decrease heart rate, but they don't decrease it nearly as well as a beta blocker does, unless it's given IV medication, and then it might be used for severe hypertension to bring that down. It also reduces the heart rate by slowing conduction through the SA node and the AV nodes, which makes them useful in treating AFib or flutter, which is why we use that to treat AFib or flutter, because that's where that dysrhythmia occurs. A slower heart rate reduces the heart's need for additional oxygen. So this would be a good one to use for angina, because when we experience chest pain, it's because the muscles in the heart are not getting enough oxygen, right? And so if we can slow that heart rate down, it doesn't require as much oxygen if it's not working as hard. So calcium channel blockers are not used for short-term relief of chest pain. We would use like nitroglycerin would be the first line for something like that, but they're commonly used for long-term prevention. So patient education should include not taking calcium channel blockers with grapefruit juice. That's another one that I have bolded, so that must be important. We do not take calcium channel blockers with grapefruit juice, especially nifedipine, as grapefruit juice can reduce the metabolism of the calcium channel blocker. So that means that we would have if it's not metabolizing, we've got all this extra nifedipine in the blood system that's not metabolizing, and you probably go ahead and take your next dose because it's scheduled, right? And that could lead to a rapid toxic dose that can be life-threatening. Okay? Remember that. No grapefruit juice with CCBs. If the patient's systolic pressure falls below 90 or the heart rate is below 60, you should withhold the dose and notify the prescriber. Also, calcium channel blockers may worsen heart failure. Make sure you assess heart sounds frequently and assess for other signs of progression regularly as well. So you'd be listening for like your crackles in your lungs and the swelling or the jugular distension. If the patient's complaining that they've got shortness of breath or they can't breathe when they lay, down flat, that you've come in and you see them kind of bent over a pillow to breathe, that's a really good indication that we've got an exacerbation of heart failure going on. Okay. Let's see. ACE inhibitors. ACE inhibitors, they have a few things. They have a few things that will come up on your NCLEX or probably on your HESI. Probably for sure on this test. So ACE inhibitors work by preventing the conversion of angiotensin 1 to angiotensin 2. And I know we all read this and we think it, and then it just goes right back out our brain right after the test. I know I had to study it when I was in anatomy and physiology, and then again when I was in nursing school, and then again when I did whatever I do in all my degrees. But it seems like every time I study it, it makes a little bit more sense. Okay, so just know that every time you encounter this, you'll remember it a little bit better and it'll make a little bit more sense. So we've got angiotensin 1 converting to angiotensin 2. Remember, this starts down in the kidneys. Angiotensin 2 is a potent vasoconstrictor that increases peripheral resistance and promotes the excretion of aldosterone, which promotes sodium and water retention. So if we've got this happening, we don't want to promote sodium and water retention, right? Because that's one of the biggest contributors to having your high blood pressure. And so we want to inhibit that. So this word inhibitor is one of those negative modifiers that's really important. So we know that we are stopping or blocking this process somewhere along the line. Okay, so as angiotensin II is reduced, arterioles dilate, reducing peripheral vascular resistance. By reducing aldosterone secretion, ACE inhibitors promote the excretion of sodium and water. Okay, so we're doing exactly the opposite. If we did not inhibit that ACE part, the aldosterone, we would see the sodium and water being retained. But we're blocking it right there where it converts from angiotensin II to the aldosterone. We're going to block that, which means we are going to promote the excretion of sodium and water, which reduces the amount of blood that the heart needs to pump, reducing blood pressure. So write that down somewhere because that might be important, okay? Write down that it reduces the amount of blood the heart needs to pump, reducing blood pressure, because we have blocked that aldosterone secretion. These drugs are safe and efficacious and are often used as a first-line drug in the treatment of both hypertension and heart failure. They are contraindicated in pregnancy and are only used if there are no safer alternatives. And this would only be if a mother had extremely high blood pressure and nothing else could be used. All ACE inhibitors carry a black box warning against pregnancy because it can be dangerous to the fetus. Adverse effects associated with ACE inhibitors include fatigue, dizziness, mood changes, and headaches. Now, this is the biggest one that you're going to encounter, and I guarantee it's going to show up on at least your HESI or your NCLEX and your test. I've never seen an NCLEX test or a cardiac test that talks about ACE inhibitors that does not talk about the non-productive cough that may occur that is reversible when you discontinue the therapy. And they will discontinue the therapy. If you've got a patient that gets this non-productive cough, the doctor will change the treatment because of that. And it's not that the cough so much is dangerous, but these medications, these ACE inhibitors, it's rare, but they can potentially lead to a fatal effect of angioedema, which is that swelling through the submucosal tissues, which could be life-threatening. And so if you start getting that cough, they just stop. Potassium levels should be monitored as ACE inhibitors do promote potassium reabsorption in the kidneys. So you might have somebody on an ACE inhibitor where their potassium level rises too high. So these are your prils. These are lisinopril, enalapril, what are the other ones? Can't think of it off the top of my head, but it's your prils. I think lisinopril is the most common one, and you will have patients all day long in a bedside setting that are taking lisinopril. Because this is a blood pressure medication, as with all of them, you should be monitoring their blood pressure before administering. And usually the doctor will give you parameters that will be like, don't give if the systolic is less than 90 is usually the lower baseline there. But if you have a patient that's like 94 and they're usually like 130, I would hold that, because that's a significant change from their baseline, and I don't want it to drop any farther than that. But if they're always in the 90s, 100s, 110s, then I wouldn't worry too much about giving it at 92 over 60 or something. I know that sounds really low, but both those numbers are regular, right? Our normal systolic is 90 to 120, and our normal diastolic is 60 to 90. So if I have a 90 over 60, that's a normal blood pressure reading. And what would the map on that be? I didn't plan on doing math during this thing, but and I probably haven't talked map with any of you because I don't see you face to face. But the mean arterial pressure, remember that's the diastolic times 2, so that's going to be 120 plus the systolic, which is 90. So that's a total of 210, and then we're going to divide that by 3. That's a map of 70, which is normal. It's not like optimal, but anything over 60 lets me know that the cells are being adequately perfused. 70 is for sure normal. Anybody in the hospital in the 60s, we're not too concerned because we expect them to be sick, right? Anyway, it's when it goes under 60 that we're concerned. See, I got off track here, so now I totally lost what I was talking about. Oh, I think I got it all. Okay, let's go to the next slide. By the way, if you've got a patient on an ACE inhibitor and they do get that cough, they'll probably switch them to an ARB inhibitor, which is not part of this presentation. You may have it in your reading. They're very, very similar. They don't have the same adverse effects. They're better that way, but they're really expensive, and so it's just not usually the first line. They'll try an ACE inhibitor first. Okay, cardiac glycosides. So this is our digoxin. Digoxin is our prototype here. It's derived from the digitalis plant. They have 3 effects on the heart. They cause a positive inotropic action. That means that it increases the cardiac muscle contraction. Okay, it makes it squeeze a lot harder. It causes a negative chronotropic action that decreases the heart rate. So it's going to lower the heart rate. And it has a negative dromotropic action that decreases conduction of the electrical stimuli. The effects of these 3 actions improves the heart, peripheral, and kidney function because cardiac output is increased and preload is decreased. So if I have cardiac output increased but preload is decreased, I'm going to improve blood flow to the periphery and to the kidneys. Edema decreases, fluid excretion increases, and fluid retention in the lung and extremities is increased. They're also used to correct AFib and aflutter. So I see that a lot. If I've got a patient that's in AFib and we don't know, well, I don't know, maybe we don't want to just jump right to shock and grabbing the paddles and doing a cardio version. Maybe you'll have a doctor say, let's try to convert chemically first, and so we'll start a digoxin therapy there to see if we can't convert. We might also try a diltiazem drip, and in fact we probably will try a dilt drip with that, and maybe even amiodarone. Amiodarone is just starting to be used more and more for the treatment of AFib and flutter, especially if they've converted. They might be put on that medication to keep them in a converted state. Anyway, that was off track. There are many nursing considerations associated with digoxin, but the most common are monitoring digoxin and potassium levels and assessing for toxicity, and monitoring the patient's heart rate at the apical pulse. Okay, that's not down at the radial and counting to 10 and timesing it by 6. That's taking your stethoscope, placing it at the apical pulse, which you know is in that mitral area, and counting for the full 60 beats per minute. Okay, you count for the full 60 beats. That's really important with that medication. Also assess renal function, as digoxin can be very hard on the kidneys. That'll show up on a test somewhere. I don't think it's going to show up on your test this time, but that's a pretty big NCLEX question, that digoxin is really, really hard on the kidneys. And that the heart rate must be taken at the apical pulse for a full minute. You've got to know that. So signs of digoxin toxicity include nausea and vomiting, abdominal pain, diarrhea, headache, irritability, depression, insomnia, confusion, vision changes. That's a big one to know. We talk about the yellow halo that's associated with vision changes, arrhythmias, and complete heart block. Okay, and our anti-anginal drugs. We're talking our nitrates for the most part, beta blockers, calcium channel blockers we already discussed, but we'll briefly mention them. Angina occurs when the coronary arteries are the heart's primary source of oxygen, which supplies insufficient oxygen to the myocardium. So it's happening when the heart muscle is not getting enough oxygen. That will cause this chest pain. This increases the heart's workload, which increases the heart's rate, preload. Preload is blood volume in the ventricles at the end of diastole. And remember, diastole is when it's at rest and it's filling back up before it contracts again. So if you have too much blood there, that's preload that has to be pumped out at the next contraction, which makes it harder for the heart to work, right? And afterload, remember, is the pressure in the arteries leading from the ventricles. So you've got that ventricle going through the artery back out into the body. And if you've got a lot of volume there that has to fit through a hose that's not growing to accommodate it, that's a lot of pressure there. And it's really hard for the heart to push that through, which takes oxygen. It just takes more oxygen for the heart to do these things. Oh, sorry. And so it takes a greater force for that myocardial contractility to be effective. The anti-anginal drugs relieve angina by decreasing one or more of these four factors. So nitrates, they're vasodilators, okay? They are usually the drug of choice to relieve acute angina. I'm sure you have all been taught or read that they're given sublingually usually. They can be given buccally, which is between the cheek. They can be chewable tablets. It can be an aerosol that's sprayed. It can be inhaled. It can be oral transdermal, and it can be IV parenterally. Nitrates cause the smooth muscle of the veins and to a lesser extent the arteries to relax and dilate. When the veins dilate, less blood returns to the heart, which means less is filling up the ventricles, which is that preload. So if you have a lessened preload, you don't have as much to try to squeeze through that blood vessel after, and the heart just doesn't have to work as hard to try to push that route through. So it also decreases the afterload. By producing preload, nitrates reduce ventricular size and the wall tension, which means that the left wall of that ventricle doesn't have to stretch as much to pump the blood. And this in turn reduces the oxygen requirements of the heart. Nitrates are rapidly absorbed, making them a first line as they work quickly and are easy to take and are inexpensive. Nitrates, such as nitroglycerin, are generally well tolerated, but they may have adverse effects that are usually transient and involve the cardiovascular system. Most common effects is headache that is due to the dilation of the cerebral vessels. And it generally diminishes soon after therapy, but if it doesn't, if it persists, then they recommend that you give acetaminophen, Tylenol, something like that to help the patient be more comfortable, because it's way more important that we get that oxygen to the heart than to have a headache, right? So because of this vasodilation, you need to be very aware of that risk for the marked orthostatic hypotension that can occur if the nitrates and calcium channel blockers are taken together. Calcium channel blockers and nitrates very, very frequently are administered together, and so you need to be really careful in your nursing assessment and your patient teaching that you're letting your patient know that they're at risk for falls, that they need to sit and stand very, very slowly to give the chance for the blood to get up to the heart and the brain. Nitroglycerin should be kept in a cool, dark place away from heat or sunlight, and even away from the body, just because of the body temperature could affect it could degrade the active ingredients in it. It should be replaced every 3 months to ensure for freshness. And I thought this was interesting, but you should remove the cotton that comes in the bottle because it can absorb some of the medication. IV nitroglycerin should be also kept away from light sources, and so you should cover the bottle to reduce degradation of nitrates due to light exposure. So a lot of facilities will have a cover that's sent up from the pharmacy specifically for that, or it's already pre-mixed and it's got that cover over. But I've been in places where I've seen them go down to the kitchen and grab a sheet of tin foil and just wrap that bottle up because they don't order the covers. Teaching about anticoagulants should include taking the drug as prescribed and have it accessible at all times. Don't discontinue the drug abruptly, and this would be if they're taking it routinely. A lot of people just carry it with them and take it PRN if they have an episode, but some people have chronic problems, and so their provider will schedule it regularly. And for those people, they need to know to not discontinue that drug abruptly because coronary vasospasms can occur. Use caution when wearing transdermal patches. Most of these patches will be ordered for 12 hours on, 12 hours off, so make sure that they're coming off, especially before you put a new one on. And many of these patches have metallic backings, and so there are some warnings concerning them, and one of them is to use caution near a microwave because it can leak radiation through that the metallic part of it, causing burns. And also you should for sure remove it before defibrillation if it comes to that, as that patch may explode with an electrical current. Okay. If taken sublingually, you need to go to the ER if 3 tablets taking 5 minutes apart do not relieve chest pain. Okay, that's very important. It's also important, we talked about this with the last test with our male erectile dysfunction drugs when we're talking about Viagra, that they shouldn't be taking it with nitroglycerin. So you may have something on your test in opposite form this time that talks about not taking it with erectile dysfunction medications, and it's for the same reason. It's the same type drug, and you're going to lead this patient to an extreme case of hypotension if they're taking both. Okay, beta blockers you may have talked about in Pharm 1, I'm not sure, but beta blockers are used in the treatment of angina, myocardial infarction, hypertension, and for different dysrhythmias. They reduce the cardiac oxygen demand by blocking catecholamine-induced increases in heart rate, blood pressure, and force of myocardial contraction. So you need to know that these beta blockers slow down the heart rate and they prevent the heart from working as hard during contraction, which reserves some energy and requires less oxygen, which would help relieve that chest pain that's caused by that. They depress the renin secretion and prevent vasodilation of cerebral arteries. They also relieve anginal and migraine pain. They lower blood pressure, and they restore normal sinus rhythm and help limit myocardial infarction damage. This is a really frontline drug that's given very quickly after somebody has an MI, is to get a beta blocker on board. The mortality rates are so much better when this is part of the protocol. There are several adverse effects that the nurse must be aware of when administering beta blockers that result from their ability to block the beta adrenergic receptor. So if you remember right, from pathophysiology, or not patho, from just physiology, that there are two different kinds of beta receptor cells, right? There's the beta 1 and the beta 2. And the easiest way, one of them controls the heart and one of them deals with the lungs. And it's easiest for me to remember that the beta 1 is the heart because I only have one heart. And the beta 2 is my lungs because I have two of those. So if that helps you, that's my trick. So blocking the beta 1 receptor is what leads to a decrease in the heart rate, cardiac output, and cardiac contractility. Blocking of beta 2 receptors may result in bronchoconstriction and increased airway resistance. And so we want to be really careful about giving a beta blocker to a patient that has asthma or COPD, because we don't want to further constrict. Beta blockers may lead to cardiac rhythm problems. They decrease the SA and AV conduction, a decrease in systolic and diastolic blood pressures, and a decreased renin release from the kidneys. Beta blockers can mask the tachycardia associated with hypoglycemia, and diabetic patients may not be able to tell when their blood sugar falls too low. This is important for you to note. Okay? If you've got a diabetic patient that's taking a beta blocker, you need to watch their blood sugars very, very carefully because it masks the symptoms and they cannot tell if the sugar level is dropping. They can cause both hypo and hyperglycemic episodes, which is an extra particular concern with these diabetic patients. Fatigue, insomnia, and weakness may occur because of the negative effects of the cardiac and central nervous systems. They may also cause diminished libido and impotence, leading to non-compliance in male patients. Okay? That's a good patient history question to ask, and I know that people don't like to do that, and I just kind of laugh it off if I have to bring it up and say, we nurses, I like to be in your business, all kinds of your business, but it's important that you assess that, because there's a really high risk of these men that experience that would not be compliant with their medications. And you don't want them to stop taking it abruptly, okay? You need to write this down. Beta blockers all carry a black box warning regarding abrupt discontinuation of the medication. Okay? They must be tapered to avoid triggering angina, hypertension, arrhythmias, and even acute myocardial infarction, and that is definitely the most serious of them all. Arrhythmias are not good either, but that MI can be triggered by stopping a beta blocker abruptly, so you've got to assess that. You do not want that population stopping because they're too embarrassed to bring that up. Okay, it is the only drug in its class that is available. Oh wait, I got ahead of myself. Hang on. Milrinone. Let's talk about milrinone. It's a, let me see if I can say this word, phosphodiesterase inhibitor. That acts as a vasodilator. That's what you need to know. It dilates the veins. And it is the only drug in its class that is available in the U.S. It benefits the heart failure patients in two ways, with both a positive inotropic effect, which means it's going to squeeze hard. Remember, it's going to get that good contraction, and also vasodilation, which decreases afterload, which makes the heart not work as hard. I know you guys have studied heart failure to the point where anything that's working the heart extra builds that heart muscle up even bigger, which means now I've shrunk my capacity for the blood on the inside, and it's all irreversible, and I'm just progressing along. So we want to slow down the rate at which heart failure progresses, because we can't cure it. We just try to get the best life that we can out of what we have left when we're diagnosed. Okay, so the primary adverse effects seen with milrinone therapy is ventricular dysrhythmias. Okay, that's big. We're giving a medication to help with heart failure, but we've caused some ventricular dysrhythmia, and we know that the ventricular dysrhythmias are the ones that usually can lead to death. That's as they spiral and turn into VFib, that can transpire very, very quickly. And the statistics on that are not really good, because approximately 12% of patients taking that drug do experience ventricular dysrhythmia. So we would want to really educate the patient on what to report, right? We would want to let them know to report any chest pain, any tremoring. You're going to want to monitor for hypokalemia and for thrombocytopenia, where we're not producing our platelets, and also hypotension. Okay, let's move on. I think we're getting close. So here's our other antiarrhythmics. Dysrhythmia is a word that defines an irregularity of the electrical conduction of the heart that causes an abnormal heart rate or an irregular contraction. They interrupt the normal electrical pathways in the heart so it can't beat properly, profoundly affecting cardiac output. There are many drugs used to treat them that are classified to where and how they affect cardiac cells. We didn't go over this earlier, and I don't want you to worry, this won't be on your test, but I think it's good to know, to be aware of these classifications. So sodium channel blockers, it's a really big group of medications, and so they have broken it down into three within the one. So they're classified as class 1, but it's class 1A, class 1B, class 1C. And we're looking at class 1A as your propranolol is the most common. 1B is your lidocaine and your phenytoin. And 1C is your flecainide. Lost my place, sorry. Okay, so it's important to know that while antiarrhythmic drugs are meant to treat cardiac dysrhythmias, they can also worsen or cause the very arrhythmias that they are supposed to treat. Okay, isn't that fantastic? I'm giving you this medication, and it's causing the very thing that I don't want to happen. But there it is. That's a thing. It's important to assess all patients receiving any of these medications for palpitations, chest pain, weakness, and fatigue. Assess for signs of a widened pulse pressure, which is often related to valve damage. I don't know if you're familiar with those signs, if you saw them in your reading, but those include ankle or foot swelling, difficulty breathing, dizziness, facial flushing, fainting, headaches, heart palpitations, and weakness, and should be reported to the physician immediately. If these signs present or suddenly worsen, especially compared to baseline, you need to let the provider know that right away. So lidocaine is a class 1B sodium channel blocker, and that's commonly given for treatment of ventricular dysrhythmias. It works by decreasing the depolarization, automaticity, and excitability in the ventricles during diastole by direct action on the tissues, especially in the Purkinje network. Important nursing considerations associated with lidocaine include monitoring your patient for signs of confusion, tremor, restlessness, seizures, hypotension, new arrhythmias, cardiac arrest, tinnitus, remember that's ringing in the ears, blurred vision, respiratory depression, which may all be signs of toxicity. Okay? Monitor serum lidocaine levels for toxicity. Monitor electrolytes, blood urea nitrogen, and creatinine levels. Patients receiving IV lidocaine must be on a cardiac monitor at all times. Monitor blood pressure frequently. So this is probably, if I've got a lidocaine drip going off, I've got my blood pressure monitor going off every 5 minutes. I'm recording it every 15. Administer parenteral lidocaine through a rate-controlled IV pump only. Okay? I'm not talking lidocaine for a toothache or one that you put maybe a little bit in before you place an IV. I'm talking I am infusing it right into the bloodstream continuously. That patient has got to be on a monitor with a rate-controlled pump. Amiodarone is a class 3 medication that is indicated in life-threatening ventricular tachycardias and V fibrillations in IV form. But it is becoming more popular in the treatment of atrial arrhythmias as well. I talked about it already. It's common in the treatment of chronic AFib. And that would be an oral dose that the patient takes at home. It is a potassium channel blocker. IV form should only be given if the patient is on a monitor and if resuscitation equipment is nearby. So when we talk about amiodarone IV, generally that's part of a code. Okay, they'll try epinephrine first, and if that's not successful, the next try usually is 300 milligrams of amiodarone, and then they'll go back to the one mil of epinephrine for a couple more tries. Let me get to the next slide. So coagulation modifier drugs. And honestly, I searched to try to find a graphic that would make this easy to figure out. And this one actually is really, really basic, where it's missing some information about all the clotting factors that lead up to it, where it's got the Roman numerals. But those were just not easy to follow at all. So I'll just read you what it's supposed to do. So coagulation is the process of blood clot formation. Clotting factors are synthesized in the liver. Okay, you need to know that. Clotting factors are synthesized in the liver. Platelets are synthesized in the liver. The technical term for a blood clot is a thrombus. A thrombus that travels through the blood vessel is an embolus. So if I've got a DVT, it's a thrombus. If I've got a PE, that's an embolus. And that means that it originated in the leg and it traveled up into my lungs, right? It's really, 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 really rare for a pulmonary embolus to originate in the lung. That just doesn't really happen. It starts somewhere else and then it moves. And the last thing you want it to do is to move from the lung into the heart. So normal hemostasis involves the complex interaction of substances that promote clot formation and other substances that either inhibit coagulation or dissolve the formed clot. Substances that promote coagulation include platelets, von Willebrand factor, activated clotting factors, and tissue thromboplastin. Substances that inhibit coagulation include prostacyclin, antithrombin 3, and proteins C and S. In addition, tissue plasminogen activator is a natural substance that dissolves clots already formed. When a blood vessel is severed or injured, clotting begins within minutes to stop the loss of blood. Coagulation factors are essential to normal blood clotting. All factors within the cascade must happen in the order shown for clotting to happen. So that means that if anything disrupts the pattern, the clot won't form properly. Absent, decreased, or excess coagulation factors may lead to a clotting abnormality. Clotting may be initiated through two different pathways, and this graphic doesn't really show that, but the intrinsic is activated by contact with damaged vessel surfaces in that pathway, and the extrinsic is activated by damaged tissue in the pathway. The intrinsic pathway is activated when plasma comes in contact with damaged vessel surfaces. The extrinsic pathway is activated when tissue thromboplastin, which is a substance released by damaged endothelial cells, comes in contact with one of the clotting factors. And so these medications that we talk about being anticoagulants, they work by disrupting the process of either the intrinsic or extrinsic in some way. At some part of that pathway, they step in and they stop it from happening. So heparin we'll talk about first. That is an anticoagulant that happens in the intrinsic pathway, and it's used to prevent blood clot formation. It cannot dissolve clots that are already formed, but you should know that clots are self-limiting and they will dissolve on their own over time. So if you've got a person with a DVT, we're not just going to run right in there with a clot buster. We're going to put them on an anticoagulant to help prevent any new clots from forming or from any new platelets from clumping up with that clot that would make it bigger. We'll try to prevent that, but then we're just going to wait it out and wait for that to dissolve on its own. So heparin works by activating the antithrombin 3, which disrupts factors in the intrinsic pathway, which I already mentioned, which results in the prevention of a stable fibrin clot. A stable fibrin clot just can't form effectively. In low doses, heparin increases the activity of antithrombin 3 against factor XA and thrombin and inhibits clot formation. Much larger doses are necessary to inhibit fibrin formation after a clot has been formed. So when we're talking about this, we might have a patient that's in for surgery that just can't be up and mobile, and they don't really qualify for SCDs, or they're refusing their SCDs. And so the doctor would probably order them to be put on heparin Q 2 times a day, maybe 5,000 units each time, just sub-Q. That's a fairly low dose, just to help prevent any formation. But if I've got a patient that's been admitted with a DVT, we need to step up our game, right? There's already a DVT there. I don't want that fibrin or the platelets to clump with it to make it bigger. And so we're going to give a higher dose to help prevent that from happening. I might even have a patient that has like a pulmonary emboli that's already in their lung, and they've got a history of DVTs, and they might be put on a heparin drip continuously, giving a higher dose to help prevent that from happening. This relationship between dose and effect is the rationale for using low-dose heparin to prevent clotting. While blood clotting time, thrombin time, and partial thromboplastin time are prolonged during heparin therapy, you need to be evaluating those labs. And those three things, that thrombin time, partial thromboplastin time, that forms the PTT. That's the name of the lab. A PTT monitors heparin in the blood. I remember that because heparin starts with an H, and when I make my T's, I put one line through the middle of them, which looks like an H. So I know PTT stands for heparin, which leaves PT to be for Coumadin, which we'll get to in a minute. If you have a hard time remembering which is which, just remember those two T's can look like an H, and that stands for heparin. However, so a PTT for a therapeutic range is normally 1.5 to 2.5 times the control or baseline. That means you need to know what their PTT was before they started therapy. For the normal person, we want it to be 1.5 to 2.5 times higher than it would be for somebody not taking the drug for it to be therapeutic. Heparin is commonly used for DVT prophylaxis in a dose of 5,000 units given sub-Q 2 to 3 times a day. When it's used therapeutically, it is given through a continuous IV infusion and is typically started based on the patient's weight for the first dose in kilograms. A potential double dose medication error could be given if pounds and kilograms are confused. So guys, please make sure that when you're weighing your patients, anytime in medical, that we are using metrics. We are weighing in kilograms because that's how medication is dosed. So make sure that you are really, really being diligent, that you are documenting patients' weights in kilograms. And then we draw PTTs. Typically, they're drawn every 6 hours while they're on that infusion. And then we titrate the dose. And most hospitals have a protocol that is nurse-driven. You don't have to get an order every time you change that. That will tell you, it will spell out specifically based on what that lab is, whether you should increase the dose or decrease the dose and by how much. And then you will check that lab again in 6 hours and move again from there until the patient receives or reaches a therapeutic level. So what would your nursing considerations be for somebody that you are anticoagulating? Because we are not letting their blood clump together, right? So I like to say, when we're talking about anticoagulants, we all want to call them blood thinners, but is that a blood thinner? No, it is not. We are not thinning their blood. We are just making it kind of slippery like. We're making it so it can't stick together, so it slides past each other, so it doesn't clump or aggregate is the appropriate word for that. I was taught in nursing school that it was like having a traffic, somebody controlling traffic with a stop sign, and there's been a wreck, and everybody wants to slow down and look at the wreck, but there's our traffic guard that's waving you along saying, keep on moving, there's nothing to see here, there's nothing to see here. That's how anticoagulants work. So I've got this patient on heparin, and I'm going to want to assess for signs of hemorrhage, for sure, right? Prolonged clotting time, thrombocytopenia, which is a low platelet count, and a hypersensitivity reaction. We should also be regularly assessing the patient for bleeding gums, bruises, petechiae, which remember those are those tiny pinpoint dots that you see on the skin. Epistaxis, which is a bloody nose. Tarry stools, hematuria, or blood in the urine, and hematemesis, which would be blood in the vomit. If you've got a patient that has too much heparin in the body and their therapeutic level is too high, then please remember that the antidote for that, I just lost my train of thought, is protamine sulfate. Sorry. Effects of heparin can be neutralized by protamine sulfate. You need to know that. Other considerations for nurses with heparin is do not aspirate before injection. Do not massage the injection site after administering sub-Q. Another trick I learned, because heparin can burn, and so can Lovenox or enoxaparin. That is a unfractionated form of heparin that I really, really prefer to use because we don't have to give it as often, and you don't have to monitor labs with enoxaparin. But they can sting going in, and when you're giving 500 units, that's a full milliliter, which isn't tons, but it's enough, and it will sting. And so I learned, and I'll say I've been a nurse for a while, but I learned recently that if you go in at a 45-degree angle instead of a 90, it doesn't tear through the muscle tissues. It's not really muscle, sorry. We give this sub-Q, but it doesn't tear through the tissues. Let me say it that way. It kind of slides through in between the tissues. And so it's not traumatizing, and they don't experience that stinging. And I will say in the last, I've probably been doing it for a year, I have not had one patient complain of stinging ever. And I always ask, are you all right? And they're like, yeah, that was no big deal. So try that out. Okay, so the next is our oral anticoagulants, and those are, the biggest one is Coumadin. You're just going to hear Coumadin you're going to give Coumadin, you're going to hear Coumadin, or warfarin is the generic name for that. There's a lot of reasons that the major oral anticoagulation used in the U.S. is warfarin. It's because it absorbs very rapidly, and it's cheap. It's cheap, and it doesn't have tons of adverse effects. Most people tolerate it well, but it can take 3 to 4 days to reach therapeutic levels. And so if you have a patient that needs to be on an anticoagulant, rarely do they just start with Coumadin. Usually they'll start with heparin and Coumadin at the same time because they could be taken together for that first few days together. You wouldn't want to do that prolonged, or you would have clotting times that were way too long. But to give the heparin, because it doesn't stay in the bloodstream for very long, at the same time you're giving the Coumadin, waiting for that to build up a therapeutic level, is a pretty common standard practice. So Coumadin antagonizes the production of vitamin K, which is vitamin K dependent clotting factors, which are synthesized in the liver as well. Before Coumadin can exhibit its full effect, the circulating vitamin K clotting factors must be exhausted. So the liver has already produced a bunch. And that's why it's taking this 3 to 4 days to reach therapeutic levels, because you've just got to wait for the body to use up what's already there. But then the Coumadin from that point on is inhibiting the production of more. It's often used to prevent DVT and to treat patients with prosthetic heart valves or diseased mitral valves. And I'll say it's extremely common for patients that have chronic AFib or a history of AFib. Maybe they've converted and they're in sinus rhythm, but there's always a risk that it will repeat. And so they are put on an anticoagulant. Most times it's Coumadin, just because it's so readily available and it's cheap, to prevent any clotting, because that's the biggest risk of AFib, is to have that blood pool up in that atrial chamber. It builds up and it pools, and where blood pools and is stagnant, we get clotting, and we don't want that clot to form right there and then to be sent down deep into the heart muscle, causing a very, very serious coronary event. So if you ever have a patient that is newly diagnosed with AFib, you should expect your patient to be put on an anticoagulant for life. And when that happens, there's going to be a lot of patient teaching that you need to be providing, because they aren't going to be familiar with any of that. Where am I? Okay, they're sometimes combined with an antiplatelet drug, such as aspirin or Plavix, or clopidogrel is the generic name for Plavix, to reduce the risk of arterial clotting. The primary adverse reaction to warfarin therapy is minor bleeding, but severe bleeding can occur. However, with the most common site being the GI tract. So patients that are taking warfarin with aspirin should be monitored diligently for bleeding, as they can potentiate the effects of the anticoagulation. Because aspirin is a antiplatelet drug. We'll talk about that in a minute. But aspirin can also erode the lining of the stomach. That's a common complaint for that, which can lead to increased risk for ulcerative bleeding anyway. And if we're already anticoagulating their blood, and now they've got this aspirin leading to an ulcer, then they're at really high risk of some significant bleeding. So that needs to be monitored pretty carefully. And you should be aware what the signs of bleeding are, and you should be teaching that to your patient to be watching. So vitamin K is the antidote for warfarin. Lab values should be monitored frequently. It's like every 2 to 3 weeks for these patients for like the rest of their life. And they get a PT-INR, and a CBC for a platelet count, and an H&H for the hemoglobin and hematocrit level. And that's because we're watching for that bleeding, and the CBC will show us a platelet count. Patient dietary education should instruct the patient to not increase their intake of leafy green vegetables or other foods high in vitamin K. Now, I want to stress, this does not mean that they can't eat foods that have vitamin K. It just means that they shouldn't eat more than they already were before, okay? Because that Coumadin is going to be based on their baseline values. And so if they're already eating those foods, that's part of their baseline. And then we're going to give the Coumadin to increase that therapeutic value. So if we're doing that and they suddenly start eating a lot more, then their level's not going to be where it needs to be, because they're going to be inhibiting the effects of the Coumadin. So just teach them to not increase or decrease, by the way. They shouldn't be suddenly decreasing either, because then that's going to make that therapeutic. It's going to make that clotting time. It won't be therapeutic anymore. It'll be way too high if they suddenly stop eating any vitamin K. A normal PT range is 1.1 and below. A therapeutic range when taking anticoagulants should fall between 2.0 and 3.0. Antiplatelet drugs include aspirin, Plavix, pentoxifylline, and let me see if I can say this right, abciximab. I swear that one they just threw some letters of the alphabet together. That one is only given IV, and that's to name a few. There are several antiplatelet drugs out there. They work in various ways, but the result is that the platelets are not able to effectively aggregate or stick together. Where anticoagulants disrupt the clotting cascade, Antiplatelets work to prevent platelet adhesion at the site of the blood vessel injury. So we're not making them be formed, we just make them so they can't stick, okay? Which actually occurs before the clotting cascade. They affect the platelet itself, therefore its effects last throughout the lifetime of the platelet. So if you've got a patient taking aspirin and it's affecting the platelet wall, that's going to be ruined for the whole life of that platelet. So, and a life of a platelet is 7 to 10 days. And so this is important to know for pre-surgical education for patients that are taking aspirin therapy, because they're going to want to stop taking that 7 to 10 days before their surgery. We don't want them bleeding out on the table, okay? Clopidogrel, which is Plavix, is an ADP inhibitor, which is a class of antiplatelet drugs that alters the platelet membrane so that it can no longer receive the signal to aggregate and form a clot, and that lasts through the life of that cell as well. Pentoxifylline is not as common. I've got this listed. It is an antiplatelet, but it is sometimes referred to as this hemorrhagic agent. So I threw that on that slide there. If we're going to talk about a blood thinner, call something a blood thinner, this would be the only one that I think would be reasonably accurate to do so, because it does change the viscosity of the blood by increasing the flexibility of red blood cells and by reducing the aggregation or platelets of platelets. It is sometimes referred to as a hemorrhagic agent or drug because it affects the fluid dynamics of the blood. It's often used for peripheral vascular disease, which for Raynaud's, that would be another one that might help that, because as it makes that blood a little bit thinner, it could get down into those constricted blood vessels a little bit easier. And then the final drug class of antiplatelets comprise the GP2B 3A inhibitors and include that Ezaximab. They're only available for IV infusion, and they work by blocking the receptor protein by the same name that occurs in the platelets' wall membranes. This protein plays a role in promoting the aggregation for fibrin clot formation. They aren't used very often. And then we've got our thrombolytics there. And thrombolytic drugs, such as alteplase or retaplase, are coagulation modifiers. Okay? These don't prevent clots, they break down clots. We call them clot busters. They lyse the thrombi in the coronary arteries, which supply the heart with blood. This reestablishes blood flow to the blood-starved heart muscle. If blood flow is reestablished early enough, the heart muscle and left ventricular function can be saved. But if not, the affected area of the heart muscle becomes ischemic and eventually is necrotic and non-functional. So in other words, these drugs are used to dissolve a pre-existing clot or thrombus, commonly in an acute or emergency situation. They are circulated immediately throughout. They're systemic. Okay, you need to know that. They're systemic. And they quickly activate plasminogen, which dissolves fibrin clots. They carry a very high risk of hemorrhage and excessive bleeding, especially in stroke victims. So for this reason, it is important to assess the time that the event happened. If it's undetermined or longer than 3 hours, these thrombolytic drugs are contraindicated. They're often indicated for patients with deep vein thrombosis, pulmonary emboli, arterial thrombosis and embolism, and acute myocardial infarction. I will say I don't see these used nearly as often as they used to be because so many hospitals have cath labs where we could get the patient right in and solve the problem instead of waiting for a clot to be bust up and dissolved. They just go in and they move it, or they open up the artery, they place a stent, they pull the clot out with a little it's like one of those Jaws games, you know what I mean. I don't know, at the circus where you grab a toy out of the bin with your claw. My mind is mush. It's my husband's favorite game. Okay, anyway, so if we do give one of those clot busters, we have to be so diligent about assessing these patients for bleeding, okay? And also monitoring for arrhythmias, pulmonary edema, hypersensitivity reactions, and monitoring those vital signs very, very frequently. And here we are with our anemia drugs. Hematinic iron, Ipoetin alpha, and filgrastim are, well, hematinic is not a drug. It's just it's a drug class, I guess. So anemia can be caused by maturation defects, and they can be caused by secondary to excessive red blood cell count destruction. Hematinic drugs provide essential building blocks for the red blood cell production. They do so by increasing hemoglobin, the necessary element for oxygen transportation. Iron deficiency is the biggest cause of anemia worldwide. Okay, iron deficiency is the biggest cause of anemia. Blood loss is a very major contributor to being anemic. These three categories of blood loss, the three biggest categories of blood loss are from hemorrhage, from increased erythrocyte destruction, and from impaired erythrocyte production. Okay? It's important that you know that anemia is often caused by blood loss. Most often caused by blood loss, probably. So iron preparations that are used to treat the most common form of anemia, iron deficiency anemia, is ferrous sulfate. So iron is absorbed primarily in the duodenum and in the upper jejunum of the intestine. Enteric-coated preparations decrease iron absorption. So a lot of these oral ones, because they can cause a lot of stomach upset, nausea, vomiting, some abdominal pain. So a lot of these pharmaceutical companies will cover them in this enteric coating so that while it's in the stomach, it's not dissolving yet, right? And it has to travel through. But the problem is it doesn't start to break down until it's past the duodenum, and that's where most of the absorption happens. And so a lot of this medication, when it has the enteric coating, is not absorbed efficiently. Enteric coated preparations, like I said, enteric coated preparations decrease iron absorption because in that form iron isn't released until after it leaves the duodenum. Iron is transported by the blood and bound to transferrin, its carrier plasma protein. About 30% of iron is stored primarily as hemosiderin or ferritin in the reticuloendothelial cells in the liver, spleen, and bone marrow. About 66% of the total body iron is contained in hemoglobin. Which is why if we're bleeding, if we've got a lot of bleeding, it could be from like being on your period is a big one for women to be anemic. It's pretty common. So about 66% of the total body iron is contained there in the hemoglobin. Excess iron is excreted in urine, stool, and sweat, and through intestinal cell sloughing. Excess iron is also excreted in breast milk. It is most important in the production of hemoglobin. The most common adverse reaction to iron therapy is gastric irritation and constipation. Constipation is huge with people that take iron. And they also need to know that it can darken the stool, so you don't want them to freak out when they have black stools. The liquid form can stain the teeth, and so some really important education there would be to rinse the mouth really well with water if they are taking a liquid form. To avoid constipation, advise your patient to increase their fluids and fiber intake. Instruct them to rinse their mouth well with water after taking liquid doses. The absorption of iron can be enhanced when it is given with ascorbic acid and decreased when it is given with antacids and calcium. So when we're talking ascorbic acid, that's vitamin C. That's a fancy word for vitamin C. And so if they could be taking their oral iron with orange juice, that's very optimal for them, for it to work effectively. But steer them away from taking it with the antacids and calcium. Iron overdose is the most common cause of pediatric poisoning deaths reported to the U.S. Poison Control Centers. I did not know that before I put this slideshow together. And I was wondering why, like, where are these kids getting this iron? Is it in some food that I'm not aware of that's strictly high in it, and they're getting into that? Like, where are these kids getting this iron? But the answer is that many of these iron supplements, because they do have that enteric coating on them, they resemble candy, and these kids get into them and eat them like candy. And so two very important patient teaching tools regarding this enteric coated. They need to know that it's not going to absorb as efficiently, and they need to know to keep that locked up really high away from kids. Okay, so in patients with severe symptoms of iron intoxication, it can lead to coma and seizures. And so the treatment for that is a chelation therapy with deferoxamine. Okay, deferoxamine. Write that down. Deferoxamine is necessary in the treatment of iron toxicity. So here we are, almost at the very end. Erythropoietin. I'm not saying that right. Erythropoietin is a substance that forms in the kidneys in response to hypoxia and anemia. And we're going to talk about it here in the anemia sense. It stimulates red blood cell production in the bone marrow, is what it does. And so if you're deficient in it, then we need to replace that for these patients with anemia. So for the patient that experiences decreased erythropoietin production, poietin alpha is given to stimulate red blood cell production. It is given sub-Q or IV. The most serious adverse effects of poietin alpha, which the brand name is Epigen, is hypertension, which can raise blood pressure to dangerous levels, and which occurs in as many as 30% of clients receiving this drug. That's high. That's really, really high. The nurse should monitor, therefore, vital signs very regularly, but especially that blood pressure. And our last one here, filgrastim, which is Neupogen, is a synthetic analog of human granulocyte colony-stimulating factor that promotes the proliferation, differentiation, and activation of the cells that make granulocytes. Filgrastim injection is used to treat neutropenia, low white blood cells, that is caused by cancer medicines. That's not the only reason that we give it, but that's one of the bigger ones. These people, these patients that are getting chemotherapy just have these white blood cells destroyed and the body's not able to replace them. And so we give this filgrastim injection to help treat this neutropenia. Because it helps the bone marrow to make new white blood cells. So it's not chemotherapy treatment. It's used to replace the neutrophils that the chemotherapy has killed, if that makes sense. It's dosed according to the patient's absolute neutrophil count. That we call that an ANC. And it's discontinued when it rises above 10,000 MM3. I don't remember what that stands for. Okay, that's the end of what's going to be on this test. I do want you to note some test taking strategies. Number one, I noticed when I went through your midterm exam, some of you took that bad boy awful fast, like 19 minutes, 22 minutes, and it reflected in your grade. I couldn't help but notice the ones that, well, there were a few that took it really fast that did well, but most that took it really fast had lower scores. So I took that test just on a whim, and I knew all the questions, and I knew all the answers. I knew I didn't even have to really read the question to know which answer I had to choose because I knew what was on that test. And it still, for me to read every word and just pick a question, took me like 22 minutes. So how y'all are doing it faster than that is beyond me. And how y'all are doing it with having to really think through the answer is really pretty telling. So my advice to you is to take your hand off the mouse. As soon as you answer a question and it goes to the next one, get your hand off that mouse, cross it in your lap, whatever it takes, because I think when your hand is on that mouse, it gets trigger happy and you just feel like you got to hurry and check an answer. But if you're not holding on to that mouse, you're going to be a lot more likely to read that question through once. And we recommend that you read that question through 3 times. There's no way that was happening with some of you that were taking the test that fast. So, and then my next recommendation is to, as you do read the question, don't look at the answers first. Just look at the question and try to answer it in your mind before you even see what the answer options are. And if you can answer it that way and then the answer is there, then most likely you're going to be right. And you won't have to second guess, oh, but that other one sounds kind of good too. Okay. There aren't that many select all applies. There might be like 2, I think, or 3 out of the whole 50. But on your NCLEX and your HESI, there will be scads of them. And so when you're taking these tests and you get a select all that applies, just treat each answer as a true or false question that's freestanding and independent from all other answers. I don't want you to get it into your head that, oh, I only chose 2 and there's 5 choices. There's got to be another one. Or I chose all 5, because that can really happen. Okay? So it's either right or it's wrong. And if it's right, click it. And if it's wrong, don't click it. And then don't second guess that based on how many you have chosen. Pay very, very special attention to keywords that are negative or positive modifiers. That's really, really important, specifically to this test where we're talking anti this and anti that, to be understanding that I'm preventing something. Okay, I'm not trying to fix something. I'm trying to prevent something from happening. So Not all of the drugs are like that, but the ones that are, I want you to really understand what it is that that drug is doing. Don't add elements to the question that are not there. We all do that. We read it. We think, well, there was this one time, or, I'm sure if they have this, that they have that too. Don't do that. What you have before you is the only scenario you have before you. You have to assume that you have all the tools that you need. Everything you need is right there at your bedside because it's the perfect world in the testing world, right? And so don't think, especially if you're practicing as LPNs already, don't think, well, this is what it's like in the real nursing world, because y'all know that the real nursing world has nothing to do with the NCLEX nursing world. And then finally, go with your first instinct. Go with your first instinct, that first thought, because you're probably right. And it's when we sit back and we try to second guess and we change the answer, 9 times out of 10, we were right and now we're wrong. And then the final is, please, I mentioned at the beginning, but be using the nursing process to guide your answers. Okay? Go back to those fundamentals. Just be thinking, what's my ADPI? What is it asking me? What step is it in here? Should help you choose your answer. And with that, I'm sorry it went 2 hours, but there was a lot of content there. So I'm hoping that this will help you study. This test opens on Tuesday morning at midnight on the 19th, and it closes at 11:59 p.m. on the 21st. So that gives you all day Tuesday. If you're up at 12 midnight, and it gives you all day Thursday. So please plan accordingly. Try not to test at the very last minute, just in case you've got trouble logging onto the internet and getting into the testing site. All those fun things that always seem to happen when we have these proctored tests. So I wish you luck. Can't wait to see how you did, and have a really good weekend.